in the New England Journal is shown here. Why isn't my name here anymore? Aufzeichnung. Well, if you can't hear me, then call me on the phone. I can't see my name on this list here anymore, but I'm not quite certain if it's working or not. But at any rate, this is a CT out of the New England Journal that concerns a 56-year-old woman who presented to an emergency room with abdominal pain. And she has rheumatoid arthritis and gets medicines along those lines. And we can see this is a spleen, and here's one kidney, and Hounsfield units of these two organs are about the same, but the noteworthy item here is the presence of gas in this spleen. I've never seen that before either. So this is probably not avascular necrosis of the spleen. Visceral leishmaniasis makes a big spleen, but doesn't make air bubbles in the spleen. Emphysematous infection of the spleen is certainly possible. A bezoar, no thank you. Leishmaniasis is spread by sandflies, to this huge liver that this patient has that has systemic leishmaniasis. There are two editorials in the New England Journal that interested me. The first is by a woman who writes about population and the environment. We currently have 7.7 billion people living on the planet. And in the 1970s, attention was drawn to the fact that the Earth can probably accommodate only about 5 billion people on the planet. By the end of this current century, there'll probably be more than 11 billion people on the planet. Of course, this is a problem for climate change. Effective methods of birth control were introduced in the 1950s. Interestingly enough, even in well-to-do countries, 40% of pregnancies are unintended, a figure that is no different than in low-income countries. No resources are being spent on research involving more practicable methods of birth control because this item has become politically untenable. Now, the person writing this editorial is, in essence, preaching to the choir. She needs to direct her attention to the old men that are in charge of the world's great religions, my opinion. The second editorial concerns physician scientists. And the senior author on this editorial is Robert Lefkowitz, and he draws attention to the fact that in 1968, it was common for trainees out of American house staff programs to go to NIH for further training, which was certainly a better deal than being sent to Vietnam. And in 1968, Harold Varmus, Michael Brown, Joseph Goldstein, and Robert Lefkowitz went to NIH for 2 years and were paid the same salaries as the rest of us who were drafted into the military and went to Vietnam. This state of affairs resulted in an excellent opportunity for US medical science to educate the best and the brightest because going to NIH was probably a better deal than going to Vietnam. Now, in 1974, the draft or compulsory military service was abandoned by the United States. Then going to NIH for additional training wasn't that attractive anymore. And Dr. Lefkowitz and the authors of this editorial consider strategies how one could perhaps change this state of affairs. And there are a number of reasons why becoming a physician scientist is less popular today than it was in my generation in 1968. My graduating class of house staff was 1970. And 2 of us got to go to NIH, and 28 of us went to the American military establishment. The draft was abandoned in 1974. Problems that confront people wanting to become clinician scientists is insufficient protected time for research, certainly agree with that. A decrease or stagnant federal and non-federal research funding, that's certainly the case. And there's a marked discrepancy in terms of remuneration for people that are working as postdocs at NIH compared to people working in house staff programs in the United States. The same is also the case in Europe. Remuneration for a PhD postdoc or somebody working at that level is about 30% less than house staff working in the hospital. And it's tough to make that difference up, so it's difficult to convince physicians that pursuing academic medicine is a worthwhile endeavor. Could this state of affairs be changed? Well, perhaps the draft should be reintroduced. That would certainly make NIH more attractive. Another possibility might be increased basic science functional coursework while in medical school, but that's probably not going to happen. A robust and sustained support for junior faculty, that would be a good idea. Protected time for research would also be a good idea, but I think that it's time to bring scholarship back to clinical medicine, which in my view, not necessarily that of the authors of this editorial, is a problem. Now, the first paper in the New England Journal concerns anemia in little kids in Africa. This is a problem, and transfusion recommendations are pegged at hemoglobin values of between 4 and 6 grams per deciliter. That's pretty severe. You would have to increase your cardiac output about 3-fold to provide the same amount of oxygen with a hemoglobin of 4 compared to a hemoglobin of 16, let's say. So the goal in this study was when should these kiddies be transfused? And then the second question is how much volume should the transfusion contain? And if we look at the patients here, as we might imagine in sub-equatorial Africa, most of the kiddies have malaria, responsible for their severe anemia. Interestingly enough, of these children, about 25% have sickle cell disease. That means that they're homozygous for hemoglobin S. So you can imagine what the incidence of heterozygosity for sickle cell, or what we call sickle cell trait, what the incidence of that must be in this region if almost 25% of the kiddies are homozygous hemoglobin S. So these kiddies come in with severe anemia, and then the strategy is should they be transfused immediately? And the kids that were transfused immediately were transfused with 20 milliliters of whole blood, or should the transfusion be delayed later within the hospital admission, where the basis for the anemia might be treated? So the kiddies that got no immediate transfusion, I misspoke. The kiddies that got immediate transfusions were given either 20 milliliters or 30 milliliters of whole blood equivalent per kilogram of body weight. And the kiddies that did not receive immediate transfusion received 20 milliliters of whole blood equivalent per kilogram of body weight. The primary outcome in this rather complicated clinical trial was 28-day mortality. So actually, the primary outcome, mortality, was uncommon in these small children, although they had a hemoglobin coming into the hospital of between 4 and 6. And here we see that what happened. The ones that got immediate transfusion by 8 hours into the hospital admission, then had a hemoglobin of almost 9, and at 180 days, they had a hemoglobin of almost 10. And the kiddies with the delayed transfusion, by 48 hours, some of them were transfused, some of them got better on their own. If they were transfused, they received 20 milliliters of whole blood per kilogram body weight. But at the end of the 180 days, the two groups look about the same. And so there's no statistical difference. So it seems to be that delayed transfusion and transfusion of a lesser amount leads to a similar outcome as immediate transfusion. And that's shown in this fairly complicated graph showing the hemoglobin levels at baseline ranging between 4 and 6, and what eventually happened to these kiddies and how much blood they got. So the result is immediate transfusion strategy resulted in fewer children who developed profound anemia. However, these findings did not translate into fewer readmissions to the hospital and did not translate into fewer serious adverse events. Now, in the second report, we compare kiddies that got 20 milliliters per kilogram body weight transfusion compared to kiddies that got the 30 milliliters per kilogram body weight transfusion in terms of their 30-day mortality. Now, these studies were done concomitantly. These are not necessarily always the same kids. Again, malaria is the predominant cause of severe anemia in these children, with 2/3 of them had malaria. And sickle cell disease, again, about a fourth of them had sickle cell disease. So their median hemoglobins when they come into the hospital is around 4. So they're pretty sick. And primary or secondary outcomes for the entire study look about the same, but the looks are somewhat deceiving because what we see here, and this illustration is a little difficult to swallow. Mortality through 180 days for all kids is no different, but if we look at the ones that had fever on admission compared to the ones that had no fever on admission, the ones that had no fever on admission did better with a higher volume of transfusion, whereas the ones that were febrile did better with the lower volume of transfusion. And that's shown in these graphical displays here. So the hashed line is the ones that got the lower volume of transfusion, and their hazard amount decreases when they're febrile, as opposed to the kids that come out in basically with no increase in body temperature do better when they get the higher amount of transfusion. Now, the explanation for that is not immediately obvious, but if we look at the hazard ratios, having a convulsion is bad, I guess. Being HIV positive is bad. This Blantyre coma scale is basically a modified Glasgow coma scale for children, and if you're in severe coma, that's also bad. AB blood group is probably bad because this blood is difficult to obtain. But at any rate, there seems to be a difference in terms of transfusion strategy in these small children based on whether or not they were able to even generate a temperature above the normal range compared to those that could. And that's shown in this table that I gathered out of the online supplement. And my explanation for this would be the ones that were so sick that they couldn't even generate a fever did better with the higher volume of transfusion compared to the ones that were able to generate an increase in body temperature, indicating that they're actually more robust. The authors tried to explain the difference on the basis of shifts in the hemoglobin oxygen dissociation curve, but the actual explanation for these findings is not clear, but they're interesting. The next topic in the New England Journal this week was chronic lymphatic leukemia, which is a common form of leukemia in older persons, shown in this graphic here. It's a little more common in men than it is in women, but it's a common cause of leukemia. So these are a bunch of B lymphocytes, and they vary in terms of size. And in order to assess what the risk these patients have, we look at how many lymph nodes are increased in size, and is the spleen enlarged or not? Is the liver enlarged or not? Do the people have a hemoglobin less than 10 grams per deciliter? Do they have a poor platelet count? And these scales were developed by Binet and also Dr. Rye. The differences between the Binet scale and the Rye scale are not immediately obvious to me, but I'm not a hematologist. There are also genetic risk factors in terms of how these patients with chronic lymphocytic leukemia do. And if they have a low risk, probably some of them don't need to be treated at all. And so we need to make clinical decisions in terms of their treatment based on how they're going to do. And molecular genetic diagnostics are important. If you're missing the short arm of chromosome 17, you're also missing P53. That's always bad. And if you have mutations in Ig heavy chain, that's not a good sign either. And there are a number of different mutations that have implications in terms of risk. But probably most important are missing the short arm of chromosome 17 or having a mutation in TP53. Now the issue here is the Bruton tyrosine kinase. And we've talked about the Bruton tyrosine kinase several times. Dr. Bruton was a pediatrician who first described combined immunoglobulin deficiency as an X-linked disease. And this disease that involves B cells is a mutation in the Bruton tyrosine kinase, abbreviated BTX. Now, the Bruton tyrosine kinase is involved in a number of B-cell related diseases. It has an important physiological function in that it interacts with the PI3 kinase signaling and a whole other bunch of pathways that have to do with whether or not cells stay alive and or whether or not they're able to perform their functions normally. Now, the Bruton tyrosine kinase can be inhibited by a drug, and that's the purpose of this report. So ibrutinib is the inhibitor of the Bruton tyrosine kinase, and rituximab is an antibody against a surface marker on B cells. And you might imagine that in patients that have some risk of having progressive chronic lymphocytic leukemia, that might be a good idea to combine these two treatments. So in this large group of patients with chronic lymphocytic leukemia, the patients were randomized to the standard care, which includes fludarabine and cyclophosphamide and rituximab. They were compared to patients that got ibrutinib and rituximab compared to the standard care. So here's the Rye scale of severity of chronic lymphocytic leukemia. You can look it up and test it out yourself. And so these patients were also genotyped in terms of serious mutations that are involved in CLL. And their beta-2 microglobulin was measured, and we can see that low-risk patients are in the minority here, and most of these patients have an intermediate risk or a high risk, so they were certainly eligible to be treated. And the patients that got ibrutinib rituximab did quite a bit better than the patients that got conventional chemotherapy, although both groups actually did fairly well. And in this forest plot, ibrutinib plus rituximab was better for everybody. And their overall survival at 3 years was also significantly better. So this isn't just progression-free survival, this is total survival. And if we look at side effects of the ibrutinib therapy, neutropenia, I guess it's no surprise. Infections were a little more common, and even hyponatremia showed up, although the mechanism of that is unclear. So it looks like ibrutinib plus rituximab is probably going to end up being standard chemotherapy for patients with CLL that have some risk that need treatment. The next topic in the New England Journal is yellow fever. And in the 19th century and the early part of the 20th century, yellow fever was the most dangerous infectious disease there was. It's an RNA flavivirus, and it causes severe hepatic necrosis, and it's spread by mosquitoes. Now, all that wasn't really that obvious at the end of the 19th century. This is Carlos Finley, who was from Cuba, happened to go to the same medical school that I attended in Philadelphia, so he's quite well known to us. He suggested that yellow fever is spread by bites from mosquitoes. This is Walter Reed, after whom a hospital was named. He was an officer in the United States Army so that he could order enlisted men what they had to do. And so he ordered some to volunteer for a dramatic experiment where mosquitoes were allowed to suck up blood from patients with yellow fever, and then these same mosquitoes were placed inside jars that were put on the arms of these poor soldiers to see whether or not yellow fever would be transmitted by the mosquitoes. Some of these poor GIs died, but that proved that yellow fever was spread by mosquitoes. And this is William Gorgas, and he instituted a big program in Central America to combat mosquitoes so that the incidence of yellow fever would decrease. Some of you have probably heard of the Panama Canal. The Panama Canal was actually begun by the French at the end of the 19th century, and they failed because of yellow fever. But William Gorgas combated yellow fever so that the Panama Canal could be built, and the canal was completed in 1914. So that's a little bit of history. Now, an effective vaccine against yellow fever was introduced in 1951 from the Rockefeller Institute. And the vaccine is extremely effective, and a single dose of vaccine probably confers a lifelong resistance against yellow fever. But there was an epidemic of yellow fever in the Democratic Republic of Congo some years ago, and they didn't have enough vaccine. So the question was what to do. So a decision was made to vaccinate people for yellow fever with 1/5 of the standard dose. And the people in charge of this decision didn't know whether or not 1/5 would result in immunity against yellow fever. So a bunch of patients were vaccinated, a bunch of not patients, people were vaccinated with 1/5 of the standard dose, and baseline samples were obtained, samples at 1 month and then samples at the end of this observation period. And what was done here is a plaque reduction neutralization test with a 50% cutoff. So if you have neutralizing antibodies, you ought to be able to reduce the size of plaques, the cell culture experiments, to look for neutralizing antibodies. So some of the people at baseline had neutralizing antibodies. Of course, the people conducting this study didn't know that at the time, because these patients from Africa weren't any different than people from Europe. Who owns a vaccination card and who remembers where it is? And it's difficult to remember whether or not you've been vaccinated, so oral reports were not accurate. So same problems that we have here. But what we see is that 1/5 of the standard dose, 98% of the people were seropositive at 1 month, and that seropositivity was maintained at 1 year. And you can go over this complicated table yourselves, but what we see here is that the seropositivity was achieved by this dose in these individuals, and whether or not they achieved it was independent of age, and it was independent of gender, as this table shows. And these data then are quantitated in terms of a geometric mean titer at baseline in these persons, and their geometric mean titer at follow-up, and you can see these scales are substantially different. So the conclusion from this study is that 1/5 of the dose of the standard vaccine should result in pretty good immunity, and at least in this paper, no cases of yellow fever were described. The review in the New England Journal is gene therapy, and we've looked at least all the papers that are published in the New England Journal or in the Lancet that involve gene therapy. This was touted as the cure of the future 20 years ago, and the review is very enthusiastic. I'm a little more skeptical because I think that all this is moving relatively slowly, and the results, some are very promising, but for the most part, the treatments are ameliorative and not curative. One of the strategies is the ex vivo delivery of gene therapy, where we harvest cells from the people, modify these cells in terms of adding genes or fixing them with or adding something else with lentiviral vectors, and then returning these cells to the subjects to look for an ameliorative response. This is done in the CAR-T strategy, for instance. Another strategy is direct in vivo delivery of the gene therapy. And one of the possibilities here is to inject a construct that contains the retinoid isomerohydrolase, which is involved in absence of this material results in retinitis pigmentosa, which is a severe, devastating form of blindness. So this strategy has also been tried, and that would be an in vivo delivery of gene therapy. And there are risks for introducing these vectors because they might destroy some endogenous gene that we need for something else in terms of insertional mutagenesis, and this risk is also discussed. And we can look at all the various trials that have been done, the CAR-T strategy to add CD19 targeted immune therapy by modifying T cells, and strategy of this nature, treating adenosine deaminase deficiency kiddies, and various things where we've looked at these studies. There have been some fairly promising studies looking at hemophilia A and hemophilia B that we've reviewed, but spinal muscular atrophy, intrathecal injection of the material, there seems to be some improvement, but in terms of actually healing these diseases, I think that this entire treatment strategy still has a long way to go. Now, last week we looked at this individual that has dermatomyositis and a chronic pulmonary fibrosis. And we looked at the rash on his hands. He's got Groton's papules, some oral ulcerations, and he was treated with an immune modulating therapy, mycophenolate mofetil, systemic glucocorticoids, and apparently his skin and pulmonary symptoms abated. Here's a young child that comes in with progressive headache, nausea, and projectile vomiting. She has an astrocytoma, and it was effectively operated upon, and presumably she got better. Now, I wanted to briefly review basophilic stippling, which is a phenomenon that you can see on peripheral smears. We didn't used to know what these stipples were all about, but this is basically RNA that should be removed from reticulocytes, and there's an enzyme responsible for that. It's called pyrimidine 5 nucleotidase, and when this enzyme doesn't function properly because of genetic alterations or because of certain toxicities, then on the peripheral smear we can observe basophilic stippling. So the patient is a 31-year-old woman that comes in with a hemoglobin of 9 and a hematocrit of 28. She's got heavy menses, she's got a microcytic anemia, and it looks like she has iron deficiency. And the appropriate things are measured, and the anemia seems explained. Interestingly enough, on her peripheral smear, she had slight basophilic stippling, which at the time was ignored. She was treated with ferrous sulfate, which you have to take for a year to fill the iron stores. It's actually an excellent treatment, but it's difficult to get people to take ferrous sulfate for a year. And that was the case here. So she comes in at regular intervals and her anemia is always worse, and she's nobody can figure out exactly what's going on. And so it had folic acid measured and vitamin B12 was measured, but she has a microcytic anemia with low iron and low iron binding capacity and low ferritin levels at least some of the time. But oddly enough, not all of the time. And once she comes in with an iron binding capacity, at this measurement, it was still low. So this anemia was not well explained. She didn't really get that much better with ferrous gluconate either. So the physicians finally considered perhaps some other causes of microcytic anemia. And somebody measured blood lead levels, and these were 100-fold elevated. And erythrocyte protoporphyrin was measured, and it was also markedly elevated, which is consistent with lead poisoning. But clinically, she didn't look like she had lead poisoning because she had no lead lines along her gingival margins, although her oral hygiene was excellent. So somebody went to her home, and she lives in a, I don't know, she could live in a lower class portion of Philadelphia for all I know. But what we see here is that the paint from her, this is a stairway, these are stairs going upstairs in this direction, and the paint is missing. So somebody did some stains for lead in this paint, and paint that was used in the United States in the 1920s and 1930s had a very high lead content. And this paint has been chipped off, and that's where the lead is from, because she's been eating it. And this condition in English is called pica. And pica is actually a Spanish word, somewhat similar to the German word knabbern. So she's knabbern on paint. I don't know why people do this. People with lead poisoning get lead lines, but only if their oral hygiene is poor. I didn't really know that. But if they have poor oral hygiene, they have bacteria that are responsible for this change here in the material that makes these lead lines. Sometimes you can see lead lines in bone x-rays. And here are some examples of basophilic stippling. And not all the erythrocytes are involved, only some of them are. And lead interferes with this enzyme that's responsible for taking this RNA out of these erythrocytes. So consumption of lead-containing materials is called pica. Now I looked to see if the psychiatrists believe that this is a bona fide psychiatric disease, and indeed they do, because the DSM-5 defines criteria for making the diagnosis of pica. But there are other sources of lead, like lead bullets. It used to be in gasoline, Ayurveda medicine, who knows? So there are, at any rate, it's an important classical topic and you should know something about it. Now, a little science review in the New England Journal involves what tumors respond to checkpoint inhibitors like PD-1 blockade and what don't. And in this experimental study, what was done here was that artificial tumors were outfitted with mutations causing microsatellite instability. Now, microsatellite instability occurs in cells that have defective DNA mismatch repair genes, and that happens in people that have non-polyposis colon cancer, or so-called Lynch syndrome, which is fairly common, a Mendelial form of colon cancer, and it features microsatellite instability. You test for the microsatellites, and if some of them are missing, then that's the definition of microsatellite instability. So what was done here, these poor mice were transplanted with tumors
And microsatellite instability was introduced into these tumors. And it turns out that the PD-1 inhibitors were much more effective in tumors that had high microsatellite instability compared to the tumors that had repair genes that were okay. I thought that was interesting. Now in the Lancet, the first topic is on radiation therapy for prostate cancer. I have no idea what ultra-hypofractionated radiation therapy is, and the internet didn't help me much, but in this study, ultra-hypofractionated radiation therapy was compared to fractionated radiation therapy in these patients with prostate cancer for whom a radiation therapy strategy was the most appropriate. And this is one of those studies where we want to see if the new treatment is at least no worse than the old treatment. Now, does the new treatment have advantages? And I was able to find out that indeed it does, because the ultra-hypofractionated treatments are much better tolerated, and the number of treatments that have to be given is also substantially reduced. So in essence, this study is about a less obtrusive therapy with the hope of a similar outcome. And the outcomes of the two strategies were the same. So this new form of radiation therapy that involves less sessions and less problems for the patients is no worse than the old strategy, but it will benefit the healthcare system by lowering treatment costs and better deal for the patients. Now, the next paper in the Lancet is very interesting because it involves a treatment for metabolic acidosis. And I used to think that the treatment of metabolic acidosis was either doing nothing or giving sodium bicarbonate. Now, I'm talking about chronic metabolic acidosis, not acute metabolic acidosis. Well, in this strategy, a binding material is given, abbreviated here as TRC-101, and it's got 4 NH2 groups on it. Now, these NH2 groups attract hydrogen ions accompanied by chloride ions. So in essence, each one of these molecules binds 4 molecules of HCl. So if you eat this stuff, and if your stomach is capable of making acid, this acid would be removed similar as would be the case if you had chronic vomiting, for instance, and what's left is, acid has to come from someplace, what's left is bicarbonate. So serum bicarbonate levels should go up. So this is basically a safety study, but what was done here was patients with chronic renal disease that had metabolic acidosis, bicarbonate less than 19 or less than 20, were randomized to this material called vivarimer or placebo. I wish they would have randomized to sodium bicarbonate, but they randomized it to placebo because vivarimer is going to be a lot more expensive than sodium bicarbonate, which is called baking soda in the rest of the world. So here are the patients. And indeed, they have chronic renal disease and metabolic acidosis and a whole bunch of other medical problems that are common in patients with chronic renal disease. Estimated GFR, about 30 milliliters per minute, pH is 7.30, hydrogen ion concentration 50 nanomoles per liter, and they have serum bicarbonates that are less than 20. So what happens? Well, flatulence didn't increase. That would have probably been the case with sodium bicarbonate. And the patients seemed to tolerate this treatment pretty well. Adverse events were no different in the two groups. Now, renal function was not an outcome. It's a safety study, but indeed, it looks like renal function was more preserved in the vivarimer group compared to the placebo group. Earlier, we looked at an adjacent paper looking at sodium bicarbonate compared to placebo, and a similar result was reported for sodium bicarbonate. But bicarbonate levels did increase in these patients from 17 to 22 compared to the placebo group. And their functional capacity in terms of how far they could walk and how well they felt and things of this nature seemed to be improved. So this study implies that vivarimer might be a reasonable treatment for patients with chronic renal disease to enable better outcomes. Now, the next paper in the Lancet was asthma in China. Now, there are about 1.4 billion people living in China, and so I would imagine that asthma is fairly common since a lot of them also smoke and pollution is a problem. So this is a survey of almost 60,000 patients, and they were studied as best as the investigators could in terms of survey, questionnaires, also pulmonary function tests, direct examinations, but they didn't have data on all 60,000 patients. But if we look at these patients, these are commonly patients that live in rural areas, so biomass use, I think that's a euphemism for having an open stove at home, occupational exposure, smoking, pneumonia in childhood, and all this sort of things, and then asthma, diagnosed by conventional means or historical or whatever the airflow limitation or whatever the investigators could, was fairly common. And in men and women, and the treatment for asthma was confined only about 1,000 of these 60,000 people that, at any rate, there's great room for improvement on the treatment of asthma in patients with in China that have symptoms of asthma, but that's not appreciated by their healthcare system. So that's the point of this study. Asthma is common. It's also common in China, and it is amenable to treatment, and that should be done. The review in the Lancet concerns fecal microbiota transplantation, which is currently approved only for patients that have recurrent Clostridium difficile. But all aspects of this are discussed in this review. Decision on whether or not this should be done, who the donors are, discussing the risk benefits with the patients, and follow-up. And there are a number of trials being done and studies that have nothing to do with Clostridium difficile, including bipolar disorder, cirrhosis, malnutrition, Parkinson's disease, psoriatic arthritis, etc. This seems to be a wonderful treatment for almost anything. So I'm curious to see how randomized trials are actually going to come down. But this is an important review if you're interested in the microbiome, which a number of people at this institution are, ought to look to see what's going on here and what can be transferred here and how this might have a beneficial effect on the patients as shown in generous figures in an interesting review. The second review in the Lancet concerns the New Zealand healthcare system, which I think is pretty good. They have a generalized healthcare system that covers all the people that live there, but that's only about 7 million people in a mostly fairly homogeneous society, although there are endogenous people and Pacific Islanders that have moved there. They have higher mortality than the people of European background, mostly related to type 2 diabetes and hypertension. That is getting better over time, whereas the mortality rate of those of European origin is also getting somewhat better. They're doing a pretty good job on getting costs down. This is a breakdown of many countries across the world, what percentage of their GDP they expend for healthcare. And Germany is here, US is here, and New Zealand is there. The last topic concerns a 9-year-old child that comes in. She has a stroke, and children aren't supposed to have strokes, so it's probably embolic stroke. So high on the list is possibly bacterial endocarditis. So she's worked up for that, and this angiogram here shows what appears to be a mycotic aneurysm. She also has a hemorrhage on this side. So all that's surgically treated, and she really does fairly well and goes home with only a mild left-sided hemiparesis. But 1 month later, she has another stroke, and this one's on the other side with other mycotic aneurysms. So the clinicians missed the right diagnosis and gave the wrong antibiotics to this patient, who did indeed have had endocarditis, but this endocarditis was caused by Q fever, which is a small gram-negative bacterium. Actually looks like a rickettsial organism. It resides inside cells, and it's known to cause endocarditis, and I think it's treated with doxycycline and something else. So this child got doxycycline and hydroxychloroquine and made a complete recovery. That's it for this week. Oh, excuse me, we're not quite done yet. Here's this poor person. Comes into an emergency room looking like this. The only thing I could think of would be Behçet's disease, but he doesn't have that. So what he has, he's got fever and a bunch of his CRP level is high, and he's got titers against Mycoplasma pneumoniae, which wouldn't have crossed my mind. Mycoplasma, we think of pneumonia and bullous meningitis, and but these kinds of lesions, at any rate, we're asked what to do. And I guess if he has high titers against Mycoplasma pneumoniae, we treat him with oral azithromycin. And that is it for this week. And thank you for your attention. And next week, we'll see what they've discovered for us this time. Thank you.